which brings us to, because that's an example of it, in terms of delivery system design, that all healthcare is local. You have to, if we go back to the little mini logic diagram, you've got to have supportive regulatory and payment processes. But in the end, who does what with whom and how winds up getting decided at local levels. And so that's one of the things I want to talk about next then by giving you an example from California. So the Primary Care Mental Health and Substance Use Services Integration Policy Initiative, also known as IPI. Trust me, I don't make up these acronyms, you guys. Was a process that started about 18 months ago, almost 2 years ago. It was a state-level work group, and it convened FQHCs, mental health, substance use at the delivery system level, the local government level, and the state level in a series of steering committee and work group activities that resulted in the reports. And the vision that was adopted as the result of this work is that overall health and wellness is embraced as a shared community responsibility. And if you think about that, that's a very powerful concept, and it does say that you've got to figure it out locally, that how we will share that responsibility together is something that we have to keep talking and working on. And you'll see here that what they decided is that services did need to be seamlessly integrated, and that it required collaboration at every level in order to make that happen. And all of that needs to be coordinated with the community's supportive capacities. So there are 10 principles in support of the vision, and you've got a document here which summarizes. This is a 3-volume report. For those of you who want to know more about it, I would recommend you just download volume 1. And then if you really get into it, you can go for volumes 2 and 3. But the piece that so you can see all the principles in the handout that you have, but the piece I really want to focus on is what they decided to do about having local conversations. So think about California. California has 52 counties, some of which are tiny, tiny little counties up in the Sierra Nevadas, and then there's Los Angeles, which is like another country. So, you know, how do you tell people, well, this is how you have to do this? So what they came up with was this idea of a framework that people could use to have a standard conversation across California, but come to different conclusions about who and how. And the way in which the continuum is laid out is that it looks at 4 levels of care, of integration: mild mental health substance use complexity, moderate, serious, and severe. And so these are the levels of mental health substance use complexity, and you'll see in a moment how that crosswalks to healthcare. For each of these columns, you'll see in the continuum, which you have in full in your handout, that the first row looks at what are the characteristics of the population. Briefly, how would we describe this population? The second row then looks at what's the estimated number of people needing services. So if I'm tiny little, Sierra County, how many people do I need to think about serving? And if I'm Los Angeles County, how many people do I need to think about serving in each of these levels of care? Then it speaks to the healthcare home physical health services that we may be made available. And those are the same all the way across, because the message is if you're serious or severely ill in terms of your mental health or substance use condition, you should still get access to the same healthcare services as is being delivered for folks with mild conditions. It gives you then for each of those levels of care a review of optimal services at each level. So what kinds of services would you offer for mild and moderate conditions? What kinds of services should you be offering for severe? Examples of interventions, and then some measures. And at the very end of it, if you'll just go to the back of your goldenrod handout where you will find this thing, you will see that this is a context for a community conversation, with the acknowledgement that providers differ among communities, and it's important to reach a community agreement on which organizations will provide which levels of service. And if you look down this, you'll see that for mild complexity, it says generally provided in primary care. For severe complexity, it says generally provided in specialty mental health or specialty substance use. And in the middle two, there are question marks. And the reason there are question marks is to acknowledge that it will be different from community to community. How much gets done in primary care, how much gets done on the specialty side. And this is a way of beginning to sort out that structure about how those services will be delivered. In some cases, and I can tell you of a case in California right now, even the severe care may be delivered in an FQHC. Let me tell you why. I'm up in the Sierra Nevadas again. There is a county in California, Shasta County, that has contracted with an FQHC to deliver services of the most intense kind, mental health services, with an FQHC because they're across the mountain pass from where the mental health services are located. And so people weren't getting across the mountain pass to those mental health services. So their solution in that county was to say, well, but there is an FQHC over there, and if they're willing to do the work, we're willing to fund them to do the work to get mental health services on the ground on the other side of the mountain pass. So that's an example in which the severity scale goes into the FQHC, the whole thing. That isn't going to happen in a lot of other counties, but we needed to leave room for those kinds of differences. The California project is moving forward with folks beginning to have those conversations, those local conversations. And the intention is to then try to bring the regulatory and policy arena in California into alignment with this set of ideas to support people actually implementing whatever their particular mix is of who does what, as long as they're clear about it and as long as they've got clear agreements about how people step up and step down seamlessly. So that's why all healthcare is local. In order to organize themselves to do that, there's several models, 3 to be exact, around the country in terms of structuring integrated care. But I want to be really clear that you understand that none of these structural organizational processes guarantees or precludes that you will get the processes of care found to be important in clinical integration. This gets back to that point before. You've got to be clear about what the clinical work is, get the structure in place. Just doing one of these organization models won't get you the clinical piece unless you do it quite explicitly. So the fully integrated medical and mental health substance use healthcare staff within a single organization has, a lot of appeal to people because it's all in the same place. And this started in some of the big integrated healthcare systems such as Kaiser, Group Health, and the VA, and it's really nice because everybody's under the same roof, everybody is a part of the same electronic medical record. This works somewhat more easily in this kind of setting. But, that's only a small subset of the world out there. And so how else do you do this? There is an example in East Tennessee called Cherokee Health Systems that is both a community mental health center and a federally qualified health center. So they are both things. They're both animals. And there's some more of these coming along. There's some more people who have been mental health centers who are getting an FQHC grant and beginning to develop these single kinds of organizations. But it did take 20 years for Cherokee to build what they've got. And they did have a rather unique financing model that made it possible for them to do it. So it's a bit of a struggle, but it is a beautiful thing in action. When you visit Cherokee, there's a behavioral health consultant in every primary care pod. not down the hall, but in the pod with the docs and the nurses as a part of that healthcare team. Because they're a mental health center, they also have a specialty mental health program. And in that program, their intensive care case management teams have primary care docs on them. So that they've really done this bi-directional integration. In the pediatric clinics, the BHC does developmental screens for every well child visit. Imagine if that were really to happen more broadly. So you go to look at Cherokee and you say, this is terrific stuff. This is the way the world ought to work. But it's a unique set of circumstances, so the next option that people have been exploring is partnerships between a community mental health or substance use organization and a primary care provider, in which they essentially embed their staff in one another's settings. And what that brings is not only a staff member, but that linkage back to the home ship, where there's supervision, consultation, billing capacity, referrals to specialists, and so on. The model here is in play in Washington State. We've got several partnerships that look like this model. As I mentioned in response to an earlier question, at the Behavioral Health Conference in Yakima last week, we had a work session on primary care in the mental health setting, and we had Neighbor Care and Navos from Seattle, and Compass and Molina from Everett, presenting on their models and what they have been doing in terms of putting primary care into mental health settings. Compass is fairly new. They just opened this spring. Navos and Neighbor Care have been doing this for about 3 years. And that population that they are serving is principally the individuals who are being served by PAC teams and individuals in the ECS program who have come into residential care close to the Navos campus. It is, one of the interesting things about this model is that each organization brings the best of what they do to the partnership. So people who know how to do primary care are doing primary care now in the mental health setting, and they bring all of that expertise. People who know how to do mental health and substance use work are in the primary care clinic. They bring all of that expertise and connection back to the specialty system. And in both of these examples of partnership, there is no money changing hands. Neighbor Care, when the Neighbor Care doc is at the Navos mental health site, he is there as a Neighbor Care doc. He does the Neighbor Care EHR on his laptop. It's all documented in the Neighbor Care system. It's billed by Neighbor Care. Same thing, Molina is covering directly their costs of running their primary care clinic that's inside of the Compass campus. So this is the way these partnerships can work. And then the third model is probably the closest to what people are doing right now otherwise, if they're trying to do anything at all about this. And that is trying to set up linkage models in which there's mental health and substance use providers trying to get linked to some key primary care providers to do referrals. And similarly, primary care clinics trying to get linked to mental health substance use providers to do referrals. This is the weakest of the three models because it depends on people getting from point A to point B to get the additional service that they need. And the research is pretty consistent in saying that somewhere between point A and point B is this chasm that people fall into, and they never get to where you're trying to get them. So it's really only as successful as access, quality of care, and making that referral linkage as tight as it possibly can be. You have an example of this in your packet as well. It's another project out of California. It's a joint project of the Department of Mental Health and the Medicaid agency. And they are working on a collaborative to do integrated care. You'll see that it has a change package, and gee, these things look familiar. Healthcare organization, delivery system design, decision support. This is the care model. You see the care model again being used in this pilot in California. And the handout that you have from this gives you some detail about their work just to get started, the checklist of pre-work activities and some suggested ways to organize the team around getting the work done. One of the things that we found in the National Council Collaborative, which was also made up of partnerships between primary care and mental health agencies, was that piece of getting organized to work as a team, when you're trying to make changes in two organizations at the same time and do that kind of in balance, keep it connected, is very tough. It's very hard for people to do. And the teams that were most successful were the ones that found a way to regularly meet, communicate, and problem solve, and had an explicit agreement about how they were going to problem solve. That is what it's going to take to make these partnerships work. So you see here the details that are in this packet. So let me stop and see what questions you have before we move to financing. And then Richard will be joining us shortly to even add to the financing discussion. So questions? This is Mike Day here, I think.
Just a clarification, please. When you were talking about the King County fishing model, how is safety net defined? Because in working in long-term supports and services, we know that many of our consumers are also experiencing either substance use or mental health situations. And so I just didn't see it in your listing.
The safety net is defined really mainly by payer category. People who are on Medicaid, people who are dual eligibles, people who are uninsured and under 200% of poverty. That was the principal definition of safety net, was people who did not have, another way of saying it is people who are not commercially insured.
Hello.
Yes.
I'm from, I guess, Adasa now. I think this is really great, but I've known some incidences where doctors are not sure what is wrong with the person, and they see, oh, you're on antidepressants, or oh, you've gone to the psychiatric ward, and as a teenager during this session, they said, it's all in your head, or you're drinking too much pop, or these are serious ones they said.
I know.
And then one doctor said, last thing we can do is do exploratory surgery. They found an issue, and then, oh, sorry, it's not all in your head, you really do have something. So how are we going to educate general practitioners and all these other people in these communities that just because someone's taking an antidepressant and they can't find the illness right away, or, I mean, this took like 3 years before this was found. But how is that going to educate the primaries to not just throw it into the, oh, it's all in your head syndrome?
I'm really glad you brought that up, because you're right, it's a very serious problem. It's one of the reasons why we see such health disparities for people who receive mental health services, is because not only do they have difficulty getting access, but once they get served, they aren't necessarily appropriately served, and yours is a good example of that. I think the key to it is moving integration along far enough that there are mental health and substance use practitioners in as many places as we can put them, because the education, you know, you can bring doctors to meetings, you can tell them what they ought to be thinking, but the real education happens on the ground when they start working with a colleague in their offices, and they begin to get educated through the process of saying, oh, okay, now I see how this works. So if we go back to the concept of team-based care and having people with mental health and substance use expertise as a part of the teams, we will be educating doctors in the real world every day, which is the way to have it stick. Mm-hmm. Well, and that becomes a part of the process that anybody who's working as a behavioral health consultant needs to address when they are working in a physician's office, is to understand, to help them develop an understanding of what the issues are and what the appropriate responses are, and to provide consultation to the primary care doc about what might be the next best step. So that, in my experience, is where you really see physicians begin to change the way they've been thinking and the way they've been doing their work, is when you actually have people on site working alongside them, helping them see some of these things differently. Other questions?